Hello. Hello, everybody. Yeah, as I told you, I wanted to start a live reporting session. Today, I wanted to start with four cases. One will be a shoulder, one will be an arm, other is an elbow joint, and one more thing is a knee joint. So these are the four cases I wanted to just do the reporting. So usually I use this structured template. So this is the structured template, what I'm showing here. This is a shoulder template. So it will be a bit painful initially to start with this template because it will be extensive. We need to remove each and every point. Like if I say supraspinal is normal, then I need to remove all these things line by line. But the thing is, we will not be missing most of the pathologies if you are using a structured template. I'm audible, right? If I'm not audible, please text me. Yeah. So by using a structured template, it will be easy for us, one thing, but it will be a time-consuming thing, a little laborious because we need to remove we need to go through each and every line. Once we use, initially, if we can use the structured template, it will be easy for us, okay? And basically not missing the most of the points within the report. So if down the line, I will show you how to use the structured template in a simpler way or a quick way. So here I wanted to start with this case. So it's a female, diabetic and hypertensive. She was complaining of restricted movement of the shoulder joint. So, so she's restricted movement of the shoulder joint. My preference of sequences in a shoulder or in most of the MSK, this thing is PDFSM. So I want all the PDFS sequences in three planes: axial, coronal, sagittal, and one T1, one T2, and and a GRE. So this is a GRE, and I also do one cartilage imaging sequence. This is G3D DES. So to look for the cartilage. So usually, my preferred this thing to look at pathologies is the PDFS imaging. So I'll show this case. I'll put full screen. Yeah. So I'll start with this coronal section. So usually I start with coronal section. Then I look at first the acromioclavicular joint. I see whether there is any acromioclavicular joint arthritis or any other AC joint pathology. I see here there is AC joint arthritis in the form of subchondral erosions, thickening of the capsule, fluid signal or hyperintense signal within the joint, and periarticular soft tissue inflammation and thickening. So this is one thing. The other thing, next I start with is the tip of the acromion. The tip of the acromion, if I see this tip of acromion, and this is a supraspinatus tendon, the space between this is reduced, if you see. So if we go a bit medially, there is a space, the space is preserved and it is filled with fluid. This is subacromion subdeltoid bursa or subacromion bursa to say. So this is the fluid within the bursa. And this, if you see, there is the space between the supraspinatus tendon and tip of acromion is reduced here. So there is mild impingement of the supraspinatus tendon. So, and next, if we come here, we see this is the hyperintense signal on our coronal image in myotendinous junction, sorry, in the distal, in the critical zone of supraspinatus tendon. So, is this normal or abnormal? This signal is normal or abnormal? Please text. Yeah, I think I'll continue. So, this signal is normal. It is a magic angle phenomenon. So there is something called magic angle phenomena where the fibers are oriented in that angle. Yeah, somebody answered it. It's normal. It is because of magic angle. Okay. Then there is minimal fluid in the glenohumeral joint, which is not so significant in this case. And so once I do this, I will look at the biceps anchor. This is the origin of long head of biceps tendon from the superior glenoid tubercle. You see here, this is the superior glenoid labrum here. Okay. And there is no, if you ask me, there is no significant tear within the superior glenoid labrum. This is the long head of biceps tendon. Okay. This is the intra-articular portion of long head of biceps tendon, and this is the long head of biceps tendon, the bicipital groove. There is minimal fluid here. So, what are the two heads of long head of biceps? What are the two heads of long head of biceps? Please answer. Then this is a long head of biceps. Okay. Then it runs into the bicipital groove here. And if you see here, there's minimal fluid in the long head of biceps tendon. Okay. If there is fluid along long head of biceps tendon, we need to mention it. Okay. Then I told you there is minimal subacromial subacromial impingement of supraspinatus tendon, minimal fluid in subacromial subdeltoid bursa, then followed by minimal fluid along long head of biceps tendon. Yeah. Long and short heads. Very good. So long head of biceps tendon, if you see, this is the long head of biceps tendon, which is coming from the superior glenoid tubercle. This is the long head of biceps tendon is intra-articular in portion. Okay. It runs in intra-articular plane. So that is one thing. So where is the short head coming from? So we have to see the short head also, right? And most of the times we write only long head of biceps, long head of biceps. So this is a tip of coracoid. So where is coracoid located? It is anteriorly placed. This is the coracoid anteriorly placed. If I palpate, I will palpate the coracoid process. So if you see, this is the acromion. I'm going anteriorly, and this is the coracoid. If you see this, there is minimal fluid beneath the coracoid. So there is subcoracoid bursa also. In this subcoracoid bursa, there is minimal fluid. Okay, done. So then if you see, these are two black lines which are coming from the acromion, the coracoid process. If you see, what are those two? One is short head of biceps. Other is coracobrachialis. So these are the two muscles. So from the coracoid process. As you're seeing, we have seen long head of biceps. So I wanted to show you short head of biceps. This is a short head of biceps. And other thing which accompanies that, we both starts from the tip of coracoid. This is a common tendon for both them. This is another is the coracobrachialis muscle. Done. So this is the coronal section, what we are seeing. Any other pathology I'm not see, I didn't tell you in this section of this coronal image, which I didn't tell now, till now. What is the pathology we are seeing here? We can see here, which is glaring at us. We see that is the axillary pouch. This is the axillary pouch, which is thickened axillary pouch. We see here, thickened axillary pouch, and it is showing hyperintense signal on PDFS image. So that is a thickened axillary pouch with hyperintense signal on, yeah, thickened capsule around the inferior labrum. Yeah, that's what. So thickened inferior glenohumeral ligament, that is also correct. Axillary pouch or inferior glenohumeral ligament is thickened and shows hyperintense signal. Minimal fluid signal is noted surrounding this. So I just told you the history. This is a 60-year-old female patient with diabetes. So diabetes is one of the risk factors or supporting factors for periarthritis shoulder. So one of the finding of periarthritis shoulder is this. This is a case of adhesive capsulitis. Along with that, we found some other pathologies like this is subacromial impingement of supraspinatus tendon, minimal fluid in subacromial subdeltoid bursa, minimal fluid along long head of biceps tendon. So these are the things. Any other thing I'm missing in this, or all most of the things are covered? Yeah. Snigdha is right. She says frozen shoulder or adhesive capsulitis. Yeah. So, any other pathology I'm missing in this, or most of the things are covered? Some other thing is there, right? So let us go to the other section. So this is a sagittal image, PDFS. I'm seeing something over here. If you see, text me. Let us confirm all other things what we have seen. So you see this tip of is loss of space between the supraspinatus tendon and the acromion process, minimal fluid, Hello? Yeah, I think I'm audible now. Yeah. Okay, let's continue. Uh, so we are there at this point. So there is thickening of soft tissues surrounding the long bicep tendon in the rotator interval. So we can see, yeah. And this is a thickened coracohumeral ligament over here. So these are all the signs of adhesive capsulitis or periarthritis shoulder or frozen shoulder. So this is done. Are we missing something? Anything in this case? Yeah. There is one more thing sitting over here. If you see, there is a linear hyperintense signal, curvilinear hyperintense signal, separating this bone from the head of humerus. So what is this point? This is the lesser tuberosity. This is the subscapularis insertion. Okay. So this is the subscapularis tendon. It is getting inserted onto the lesser tuberosity of humerus. I'm going to the axial image of the same patient. So if you see, so this is a hyperintense subcortical edema, and this is a subscapularis tendon. It is also showing increased signal intensity on PDFS images. So there is an avulsion with no obvious displacement of this lesser tuberosity of humerus. So done. So these are all the things what I have noted in this case. So if you see the labrum looks relatively good for the age. It is 60 years. So then we have this is again long of biceps tendon in the bicipital groove. This is lesser tuberosity, this is a greater tuberosity. So as we see, I have shown you this. So if we are using a structured template, then it will be easy for us to not miss most of the findings. So you can see first is the bones, normal signal intensity. So is the signal intensity normal, or saying is there any marrow edema? If you see this, there is some marrow edema sitting here. And if you see here, you can write some, there is undisplaced avulsion of lesser tuberosity of humerus at subscapularis tendon insertion. That point we can write. Supraspinatus, how is the supraspinatus? Supraspinatus appears normal, no obvious signs of tendinitis or tendinosis in this case. So if it is tendinosis or tear, if tear, then location, whether it is interstitial or critical zone, or it's involving anterior fibers or posterior fibers, whether it is involving articular surface or bursal surface or interstitium. Then if it is partial thickness or full thickness, it is it or a complete tear. Full thickness is different and complete tear is different. I'll show you further. Then what is the shape of tear? If U shape, L shape, crescent shape, if you want to mention, you can mention it. Size of tear, AP diameter and transverse diameter. Then retraction. If there is a full thickness tear of supraspinatus tendon, then usually we'll have retraction. Whether it can be like a stage 1 retraction, stage 2 retraction, or stage 3 retraction. So anything till this is stage 1, mid-humeral level stage 2, and beyond this is stage 3 retraction. So this is about this tear, what we have to see. Then infraspinatus tendon, we have to look at the infraspinatus tendon. If you see, this is the sagittal image showing supra, this is the infraspinatus tendon. So we have to see the infraspinatus tendon. If there is a large tear in the supraspinatus tendon at its, the tear usually extends into the infraspinatus tendon. So supraspinatus tendons and infraspinatus tendon tears coexist. So then we have to see the subscapularis. Here we can see there is mild edema of the subscapularis, small interstitial tears are there. And also there is avulsion of lesser tuberosity of humerus at subscapularis tendon insertion. So that is the other thing what we have to mention. Then about teres, if there is anything major about teres major, we need to mention. So where is teres major? If we go big down, we can see. Actually, it starts here. So you can see this is a muscle of teres major. So most of the scans will not cover our teres major. It will be located somewhere here. So usually there is a synonym, right? So there is a mnemonic, what do you call, lady between two majors. So you'll have pectoralis major here, teres major here, latissimus dorsis is sitting in between. So if you go a bit down, we'll see that section. So then is quality of muscle. How is the muscle? So whether there is any fat infiltration or atrophy of the muscle, we need to look at. So if there is, then we have to mention the Gautilier's classification. There is a Gautilier's classification that will say there is something called Gautilier's grade. So that we need to mention. Then rotator cuff muscles and other muscles, same, any atrophy or any abnormal signal. Then we have to look at the long head of biceps tendon. As you've seen, is there any subluxation present or absent? Whether it is sitting in the center of the bicipital groove or not. If you see this here, there is some interstitial tears within the distal subscapularis tendon, and also the long head of biceps tendon is somewhat medially subluxated within the long head of biceps within the groove. So that is actually type 1. Bennett's classification, type 1 biceps instability. Okay. So here there is type 1 by Bennett's type 1 instability. So that is about long head of biceps tendon. Then subluxation is there or not, interstitial tear is there, tendinosis is there or not, or is there any full thickness tear of biceps tendon that we need to look at. Then other than that, glenohumeral ligaments, like we have already seen, like the superior middle and inferior glenohumeral ligament. In adductor capsulitis, there is thickening of the inferior glenohumeral ligament, which I have seen. So that is there. So any tear, usually if it is a arthrogram, we can better depict them and better study them. So then rotator interval, we have seen now, is it normal? There is synovitis or tear within the rotator interval, like coracohumeral ligament tear, or is there any abnormal signal intensity in the rotator interval? We need to mention. Then we have subacromial subdeltoid bursa. Also, we have seen minimal fluid was there that we need to mention. Then coracoacromial arch. So acromioclavicular joint with normal arthritis. Arthritis is there. There is no dislocation. Usually in trauma, we mention Rockwood classification, and based on that, we'll give the dislocation. So I think, yeah. I'll share these templates also. Yeah. So acromion type, whether type 1, type 2, type 3. So that we need to mention. So then what we have, coracoacromial ligaments, coracoclavicular ligaments, coracoid. If you want to, if there is some pathology, we need to mention, otherwise we can leave it. So most of the times, these coracoclavicular, coracoacromial ligaments, usually they are, we need to mention it in what is say, so yeah, so we need to mention in the trauma, like with the AC joint subluxation or AC joint dislocation. So yeah, and nerves, vessels, axilla, whether it's normal or not. Sometimes we'll have axillary lymph node enlargement, which we see when we now, and some part of brachial plexus can be seen in the shoulder. That we need to mention if there is any pathology or hypertension signal, perineural inflammation. So then suprascapular and sphenoglenoid notch. So suprascapular notch and sphenoglenoid notch, if you see here, this is the region. So usually there will be neurovascular bundle, suprascapular nerve sitting over there and the vessels. So sometimes we find ganglion cysts over there. So that's the reason we need to mention about them also. So if we use a structured template, most of the times it is difficult to miss the pathology. And also we need to know the pathology also. Yeah. So is it necessary to see SGHL in every case? Look for abnormal signal. If you see any abnormal signal, abnormal structure, then we need to dive into that. So if I'm seeing rotatory interval and if I find some abnormal signal, then look at supraglenohumeral ligament. So like if in that region, if I'm not finding any abnormal signal, we don't need to search for the normal structures usually. This is one case which I wanted to show. Then the second thing, yeah, this is a case of like a 60 years old patient. His arm was done. The complaint was swelling in the proximal arm. So swelling in the proximal arm, that was the complaint. So yeah, you see here, there is something sitting over there, which is this is the star image. It is showing hyperintense signal. I'm seeing next, I'm showing T1. It is hyperintense signal. And I'll next show the T2. T2. Yeah. T2. How is it on T2? It is hyperintense. It is hyperintense on T1 and T2. So what it can be? It is a hematoma. So it can be hematoma. Where is it sitting? It is sitting in the flexor compartment of the arm. So I'll show you the sagittal. Yeah, yeah. So if you see this, it is sitting almost like in at the mid shaft level of the humerus. Okay, and there is diffuse muscle edema, soft tissue edema surrounding it. Came with history of trivial trauma and swelling in the mid arm level. So, uh, what could be the pathology? Are we seeing something over here? Are we seeing something? Hematoma is there. Is it a muscle hematoma or intramuscular hematoma? Or it's only hematoma here in this case? I'm scrolling. I'll start scrolling from the superior most part, whichever is available. Yeah. In the previous case, I was mentioning about teres major, right? See here. This is the one. Okay. Teres major muscle insertion. This is pectoralis. Okay. Okay. So I'm going from the level of shoulder now. Whatever is available. Yeah. This is the first section, superior most section available for me. So I'm starting from here. If you see this is the glenohumeral joint. So I'm going down, 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 down. There is something, a curvilinear T2 high point and structure sitting here, followed by a large hematoma, intramuscular hematoma. So this, if you see, this thing is our long head of biceps tendon, torn long head of biceps tendon. I'm going superiorly again. If you see, there is an empty in, long head of okay. This, if you see, there is this is empty and there is no long head of biceps tendon sitting over here. This is retracted. This got retracted and it is here, almost retracted till the level of mid humerus. Okay. If you see, this is the superior glenoid tubercle, and some part of the intra-articular portion of long head of biceps tendon appears over here. After that, nothing is seen. So we need to mention what we need to mention. There is hematoma sitting within the long head of sorry, in the biceps muscle at the level of mid shaft of humerus, and the tendon is retracted. And how much is it retracted? Approximately from the level of this bicipital, starting of bicipital groove portion. I'll mention it. So approximately 10 centimeters in length. So that helps them in understanding whether they can go for reconstruction, and if they're going to reconstruction, okay, the tendon can be pulled up back or not. So that is one thing. So there is a large hematoma sitting in the longer in the biceps, and there is a retracted biceps tendon. If you see here again, I'll show you. This is the retracted tendon. So I'm going up. Yeah. So if you see this muscle here, this muscle is a long head. There is hematoma. Done. What is this? Short head of biceps. This is short head of biceps. This is a long head of biceps. And intermuscular plane also, we are seeing a lot of edema and fluid signal. Yes, it's avulsion of tendon. So this is the case of avulsion of long head of biceps tendon with retraction of tendon intramuscular hematoma. So what are all the other structures we need to look at? Bones, muscles, neurovascular bundle. So there are a lot of nerves within the arm. Major nerves are the median nerve, radial nerve, and ulnar nerve. Let us see it clearly in the anatomy section. So even for this arm, we need, if we use uh, a standard uh, template, that will be easy. Like bones, what are the bones? If possible, if sometimes we can in the arm, the elbow will be elbow joint will be covered. So radius and ulnar need to be mentioned. Humerus, any lytic lesion, any abnormal marrow signal intensity. So then bones and joints and muscles. So in muscles, like what is the bulk of the muscle? Morphology, any fatty atrophy, like how we have seen in the rotatory cuff. Then any mass in the muscle, if you see any mass. Here we are seeing a hematoma. So the same thing needs to be mentioned: location, size, margins, enhancement if contrast is given, and involvement of adjacent structures, and infiltration of the neurovascular bundle. Sometimes there will be a mass which is due to hypointense signal, and very close in proximity with the neurovascular bundle. It can be a nerve sheath tumor. So proximal structures, whether it is infiltrating or the structures are obscured by the lesion, that gives some diagnosis. So next we see the neuro tendons, biceps, triceps. If elbow is covered, then forearm flexor extensor tendons, any peritendinous fluid or tenosynovitis. So it is there with any tendon. So neurovascular structures, median nerves, what we have discussed. So then vessels, soft tissues, then facial planes, whether preserved or thickened. So any mass lesion within the soft tissue, lymph nodes, if axilla is covered, and sometimes even in the arm we can see subcutaneous or soft tissue lymph nodes. So these are the things we need to mention in an arm report. So this is about case of avulsion of long head of biceps. Yeah, this is done. We'll move to the next case. Any doubts till now? I'm moving to the next one. This is the elbow. So this is the elbow report. Yeah. So as I told you, I take 3 planes of PDFS. So I think here the technician had not done it. They have done 2 axial step, 1 coronal step, and a SAG PD. So done. So what I have here, elbow joint, what are the bones? Distal end of humerus, radius, ulna. So how do I, if there is something like, if I say this is a distal end of humerus, what is the structure? This is lateral epicondyle. This is medial epicondyle. Okay. Then this is the head of the radius. This is olecranon process of ulna, coronate process of ulna. If we see SAG, we can see better on sagittal images, olecranon process and coronate process. Yeah, this is olecranon, this is the coronate process. So if there is there is some fluid, say some erosions are there, subarticular erosions are there here, and there is fluid only, if there is fluid within this compartment of the joint, significant amount of fluid only in this compartment of the joint. How do I mention? It is radiocapital joint. If you say this, ulnotrochlear joint. So ulnotrochlear, radiocapital joints. So we can mention them separately. So this is the ulnotrochlear joint, radiocapital joint. Then we have, yeah. So what is happening here? If I see, I'm going to T2 axial. This is a flexor compartment, this is an extensor compartment. As we start with, this is the olecranon process, tip of olecranon, we have insertion of triceps tendon. What is this beautiful small muscle? Anconeus. This is a anconeus. So these are the things. So there is minimal fluid is there within the joint, more in the radiocapital joint. So minimal joint effusion predominantly in the radiocapital joint. What is the pathology? I think most of you have got it. Most of you have got the diagnosis in this case. It is a simpler thing. What is this? There is a tear, increased signal intensity in what is that? What is the tendon called? Okay, what is the tendon name? What is the tendon called? Common extensor origin tendon. So it's on the radial side, lateral side, we have common extensor origin, medial side, ulnar side, we have common flexor origin tendon. So this is the common flexor origin tendon here. This is the common extensor origin tendon here. So any tendon, any ligament, as I told you in the previous sessions, that will not have a point insertion. If you see here, this common extensor origin tendon is almost inserting for a length of 1.8 to 2 centimeters. It starts from here, inserts till level of here. So there is a tear within the common extensor origin. So this is a tear, common extensor origin tendon tear. It's an interstitial tear. Yeah, it's an interstitial tear. So outside fibers are not involved, inside fibers are preserved. So, and there is no significant marrow edema sitting over here. Okay. Mm, okay. Hyperintense signal in this epicondyle with minimal fluid adjacent to the epicondyle can be there in lateral epicondylitis. Similar thing you'll also see in medial aspect, that is medial epicondylitis. Or then we can, in the tendon, if there is a tear, common flexor origin tendon, then it can be a common flexor origin tendon tear. It can be a partial tear, full thickness tear, interstitial tear. Okay. Then if we see, then we have seen those. And if we see this, this is some collateral ligament over here. There is mild edema, but ligament appears intact. Is a radial collateral ligament. Radial collateral ligament. Then we have ulnar collateral ligament. If you see this fan-shaped band sitting over here is a ulnar collateral ligament. It has different parts. I'll explain it later. So that is collateral ligaments over here. What is another ligament? If you see, uh, here, usually mention it most of the times. Yeah. So okay, those are the ligaments, and then other than that, there is an annular ligament at the neck of radius. Until unless there is some dislocation or radial neck dislocation, we cannot really appreciate that. So those are the things, and we look for the neurovascular structures, basically nerves in the elbow joint. So if you see, this is the ulnar side, and if you see, this is the nerve which goes. This is our cubital tunnel, and posterior to the medial epicondyle. This is the ulnar nerve. Yeah. So this is the ulnar nerve. If you see the common flexor, okay, this is the ulnar nerve. So what are all the structures we need to look at in the elbow? So bones again, and articular cartilage, whether there is normal articular cartilage or any chondropathy. Joint effusion, I already mentioned. Olecranon bursa. Sometimes we have fluid in the olecranon bursa, also called student's elbow. So yeah, usually in this location, we'll find fluid, posterior aspect of the olecranon process. So next we have the ligaments, ulnar collateral ligament, radial collateral ligament, and lateral ulnar collateral ligament. Like ulnar collateral ligament has two bands that I told you, so that we can cover in next section. Common flexor, common extensor origin tendons, I have shown you. Where is long of biceps tendon? So we have spoken like where exactly it inserts. It inserts onto the radial tuberosity. So on the radial tuberosity, if you see sagittal, yeah, I have something, but can I show? Yeah. If you see here, this one, this is the long head of tendon. Okay. It also doesn't just go and insert onto the tip of radial tuberosity. It gives fan-shaped fibers. If you see here, this is the long head of biceps tendon. This for this, it goes and inserts onto the. How is it inserting? It's inserting on the ulnar aspect of the radius. See, while posteriorly and towards the ulnar aspect. Why? What is the one more function of biceps? Biceps function of biceps is, if you see, um, yeah, it's not only flexion but also supination. So it helps in supination. So that's the reason it is getting inserted over there. When this muscle is pulled, there is action of supination also. Yeah. So then that is about the long head of biceps tendon. Mm, yeah. Then uh, triceps tendon, other skeletal muscles. Is there an edema, abnormal signal, or fatty atrophy of all these muscles we can need to mention? Now, the ulnar nerve, median nerve, radial nerve, posterior interosseous nerve. If we are covering the proximal elbow, we can see the posterior interosseous nerve. Posterior interosseous nerve is like if we, this is a see, this is a radius, neck of radius. What is this muscle? This is a supinator muscle which is surrounding the neck of radius. This is the head of the radius. This is the neck of radius. This muscle is supinator. So if I see, most of the things are not covered, but if you see this here, the radial nerve will pierce this supinator and goes. If I'm taking bit lower sections, I can see. So the radial nerve will pierce the here you can see. If you see this now, radial nerve will pierce the supinator, and the posterior sorry, the radial nerve gives posterior interosseous nerve branch. The posterior interosseous nerve pierces the supinator and goes into the, this is the interosseous membrane. This is the posterior. Here we have posterior interosseous nerve. We have anterior interosseous nerve. So posterior interosseous nerve is the branch of radial nerve. So just before piercing the supinator nerve, it gives a branch that is posterior interosseous nerve. Done. So that's about the radial nerve. Then, so these are all these structures needs to be looked for. Okay. In detail, anatomy of these nerves, I'll explain in another session. This is about elbow, a case of an elbow. And next we have a knee joint. This is the last one. So almost 44 years old patient. So patient had locking of the knee joint, history of previous trauma, neglected. So I have almost like what, 3 PD, one screening CT. Screening CT was showing joint effusion. Quality of bone is good. No osteoporosis. No significant uh, osteoarthritic changes in this CT. Yeah. So I'm going into the PDFS image, SAG. Okay. Sagittal PDFS image. What is there? There is moderate joint effusion with the fluid extending into suprapatellar bursa. Moderate knee joint effusion with the fluid extending into suprapatellar bursa. There is chains of tendinosis seen within the quadriceps tendon and also patellar tendon, distal patellar tendon, which was hyperindent signals, right? Patchy areas of hyperindent signal, tendinosis. So then this is about the joint effusion, moderate knee joint effusion. Anything we are seeing, there is internal derangement of the knee. So any significant changes are we seeing? Um, so what we are seeing? Yeah, you can see there is this. What is this sign called? Double PCL sign. This is double PCL sign. And if you see, there is no ACL. ACL is there is full thickness tear of anterior cruciate ligament. Okay, there is a double PCL sign here. What is happening to the medial meniscus? Anything in the medial meniscus? What is happening to the lateral meniscus? If you see, yeah. So, yeah, very good. Bucket handle tear of medial meniscus is there. If you see, this is a bucket handle tear of medial meniscus. Better we can appreciate on a coronal image. I'm going to the coronal image. If you see, this is the body of medial meniscus. This is a retracted portion of the medial meniscus. There is, if you can see, in the intercondylar notch, the flipped meniscal fragment is seen. So how do we write it? It's a bucket handle tear of medial meniscus with the flipped meniscal fragment seen in the intercondylar notch region. So see this, you can beautifully how how it is seen. So it's not beautiful. So yeah. So the flipped meniscal fragment is seen in the intercondylar notch. Okay. Other than that, what we have, some other small pathologies in this case, we have grade 1 sprain of medial collateral ligament. There is fluid, but no significant tear. Then we have, there is mild signal, altered signal intensity within the femoral attachment of lateral collateral ligament. You can mention it as grade 1 signal. There is grade 1 or grade 2. It is intermediate actually. So few fibers appears ill-defined. So we can mention it as grade 2 signal or tear in the femoral attachment of lateral collateral ligament. This is our popliteus tendon, popliteus muscle. Okay. So that is there. Then lateral medial collateral ligament we have mentioned. Then we have seen the bucket handle tear, full thickness tear of anterior cruciate ligament. Then if we go to the lateral meniscus, what is happening to the lateral meniscus? If you see, there is meniscocapsular suppression. Meniscocapsular suppression is there. And also there is a grade 1 horizontal signal in the posterior horn of lateral meniscus. If you see, what is this? It got separated. I'm tracing it up, going up, going up, going up, going up. So this is ligament of Risberg. So this is a ligament of Risberg. If you see, this is PCL. This is posterior to this, and it's the ligament of Risberg. Usually, this ligament of Risberg and is separated from. In this case, it got separated from the posterior horn of lateral meniscus. We see this cleft, fluid like cleft in between. Okay. Yeah. That is meniscofemoral ligament, right? Posterior meniscofemoral ligament. It starts from posterior horn of lateral meniscus and seen posterior to the posterior cruciate ligament. Then, if you see in axial, what is that? Patellar cartilage overall looks good. Okay. And there is edema or sprain of medial and lateral patellar retinaculum. Okay. If you see, mild fluid is there. Okay. In the antero medial aspect of the knee joint in the subcutaneous plane. As we mentioned in the previous videos, this is our pes anserinus bursa. No signal, like there's minimal fluid, but no significant inflammation seen in the pes anserinus bursa right now. So yeah, so this is a case where we have seen all these pathologies like yeah. So what we have seen: full thickness tear of anterior cruciate ligament, bucket handle tear of medial meniscus, separation of posterior meniscocapsular separation of lateral meniscus, grade 1 horizontal tear, posterior horn of lateral meniscus. Okay. Moderate knee joint effusion with the fluid extending suprapellar bursa, grade 1 sprain, medial collateral ligament, grade 2 sprain, femoral attachment of lateral collateral ligament. Yeah, almost these are the pathologies what we have seen in this case. Yeah. So if you see here, this is the structure template where we are looking at the bone, cartilage, like other joints. Then joint effusion is there or not. Any loose bodies are there. ACL, anterior cruciate ligament, posterior cruciate ligament, whether normal, sprain, partial thickness, or full thickness tear. Then medial collateral ligament, same. Normal, sprain, partial, or complete thickness tear. Then medial collateral ligament, deep fibers of medial collateral ligament, that is meniscofemoral, meniscotibial, that will I'll show you. Then the normal or sprain or partial tear or complete tear, same. Lateral collateral ligament, anterolateral ligament. So then menisci and other structures like medial meniscus, normal or any degenerative signal is there or is the tear. Posterior meniscocapsular junction, any ramp lesion. Separation of posterior meniscocapsular separation is a ramp lesion, medial meniscus usually. So it usually associated with ACL tears. Okay. So then lateral meniscus normal or the same thing. So popliteo meniscal fascicle and meniscofemoral ligaments. We need to mention about the meniscofemoral ligaments also. Like we have seen the ligament of Risberg now. Postlateral cornel, which includes lateral collateral ligament, biceps femoris tendon, then posterolateral joint capsule. So then popliteofibular ligament, and popliteus tendon and bursa. And this semimembranous tendon, postlateral joint capsule, oblique popliteal ligament, extensor mechanism like in the patellar alta is there or baja is there, medial patellar retinaculum, lateral patellar retinaculum, patellar tendon, quadriceps tendon, and then when we have this popliteal fossa, is there any Baker cyst is there or not? Nerves and vessels, how are this nerves and vessels and the popliteal fossa, gastrocnemius muscle, and other findings like iliotibial band, whether there is any inflammation or thickening and tendinopathy, pessancerinous bursa, pessancerinous tendons, and like what are the pessancerinous tendons? Three tendons, their ropes, sartorius, gracilis, and semitendinosus. These are the pessancerinous tendons. And proximal tibiofibular joint, how is the proximal tibiofibular joint, and other skeletal muscles. So yeah, someone was asking, show me the arcuate ligament. Arcuate ligament is seen on the lateral aspect of the this thing. So it is like yeah. This we see here, this compartment here. This part is the place for the arcuate ligament. And here it's almost like it will blend with the posterior joint capsule and reinforces it. So and in this place, almost in intercondylar region, we have this place. We have the oblique popliteal ligament, arcuate ligament, and oblique popliteal ligament. If there is any breach and this fluid is coming out, we can mention the tear of arcuate. If there is breach and fluid coming out here, then we can mention it as an oblique popliteal ligament tear with extension of joint fluid into the posterior soft tissues. I think most of the things are done, and I was rushing. Uh, yeah, I think this is the session. And any doubts, you can please put it in the chat. I can answer the queries for next 5 minutes. Thank you. Okay. If there are no queries, I'm closing the session. Thank you very much for attending.